Okay, let's unpack this. Welcome to the deep dive, where we take complex topics, distill them into essential knowledge, and really help you become truly well-informed. Today, our mission is to dive deep into a condition that affects millions globally, often silently, yet carries profound health risks. Hypertension or, high blood pressure.
Exactly. And we're going to explore not just what hypertension is, but its far-reaching impacts on your body, how its definition and treatment have actually evolved based on some cutting-edge research. And critically, the vast array of strategies available to manage it, both pharmacological and non-pharmacological.
Our goal for this deep dive is to equip you with a nuanced, mastery-level understanding of hypertension, helping you grasp the complexities that truly matter in this critical field. We'll go beyond the basics. We'll examine the nuances of various drug classes, their mechanisms, side effects, and how they're chosen for individual patients. You'll walk away with a truly comprehensive picture. Understanding this pervasive health challenge at a level that, enables insightful conversation and informed decision-making. Let's start with the sheer scale of the challenge. How prevalent is hypertension really? And what makes it such a significant public health concern?
Well, hypertension is, without a doubt, the most common cardiovascular disease. Its impact on public health is truly staggering. Think of it as a silent, insidious threat. When your arterial pressure is consistently elevated, it directly causes the left ventricle of the heart to thicken. That's called hypertrophy. And it also triggers pathological changes in blood vessels throughout the entire body. These aren't minor issues. They really set off what you could call a deadly domino effect, escalating the risk for some of the most serious health conditions out there.
A deadly domino effect.
Yeah.
That sounds pretty serious. Could you explain what kind of complications we're actually talking about here?
Absolutely. Hypertension is the principal cause of stroke, which, as you know, can be absolutely devastating. It's also a major risk factor for coronary artery disease, which in turn leads to myocardial infarction heart attacks, basically, and sudden cardiac death. Beyond that, it's a significant contributor to heart failure, where the heart just struggles to pump blood effectively, and renal insufficiency, meaning kidney damage. It can even lead to something called a dissecting aneurysm of the aorta, a truly life-threatening condition where the wall of the body's main artery actually tears. And the really scary part, the silent nature of hypertension, means many people don't even realize these dangers are building up until, bam, a major event occurs.
Given how widespread it is, does its frequency change much with age?
Yes, significantly and predictably. The prevalence of hypertension increases markedly as people get older. To give you some perspective, about 50%, half of people between 60 and 69 years old, have hypertension, and this figure increases even further beyond age 70. So while it can affect anyone, it certainly becomes much more common as we age. It highlights the kind of cumulative impact of various factors over a lifetime.
So if it's so incredibly common, how are we doing at managing it? Particularly here in the U.S., are we doing a good job?
That's a crucial question, and the numbers tell an interesting, maybe somewhat concerning story. According to a 2014 survey, while a high percentage of those with hypertension, about 81.5% are aware they have it.
Okay, that's good awareness.
Right, and 74.9% are being treated. But, and this is the kicker, only a bit over half, 52.5%, are actually considered controlled. So this reveals a pretty substantial gap between awareness, getting treatment, and actually achieving effective blood pressure control. It shows we have, well, a lot of room for improvement.
That is a significant gap between knowing you have it and actually getting it under control.
Yeah.
Can we do better, and if so, how?
Oh, we absolutely can. And we have compelling evidence that a comprehensive, systematic approach can make a profound difference. A large integrated healthcare delivery system in the U.S., detailed in a 2013 study, demonstrated remarkable success. Between 2001 and 2009, this program managed to increase the number of patients diagnosed with hypertension by a staggering 78%.
Wow.
But even more impressively, the proportion of subjects actually meeting their target blood pressure goals jumped from 44% all the way up to over 84%.
That's truly an incredible improvement. What were the key things they did? What were the strategies that drove that success?
Their success was really driven by several key proactive and systematic strategies. It underscores the power of a coordinated approach. Firstly, they implemented electronic hypertension registries to track control rates, in real time, allowing for immediate insights. Secondly, they provided regular feedback to healthcare providers, fostering continuous improvement and, frankly, accountability. Thirdly, they focused on developing and frequently updating evidence-based treatment guidelines, making sure care aligned with the latest research.
Makes sense.
Fourthly, they actively promoted the use of single-pill combination therapies, which, as we'll get into, can significantly improve patient adherence by simplifying things. And finally, consistent follow-up blood pressure checks were a cornerstone, ensuring patients stayed on track and allowing for timely adjustments. This whole multifaceted approach, it truly highlights that organized interventions can make a profound difference in control rates.
Okay, so given these efforts and evolving understanding, how exactly do we define hypertension today? And what are the targets for treatment? Have these definitions stayed the same over time?
Oh, far from it. The definition of hypertension and the treatment goals have evolved significantly over the years. They're continually guided by results from critical intervention studies. This isn't a static field at all. It's constantly being refined by new, robust evidence coming out.
Can you point to one of the most impactful studies, one that really reshaped these definitions?
Yeah, a landmark study was definitely the SPRINT study. It was conducted in non-diabetic patients who had increased cardiovascular risk, and the study was actually stopped prematurely, which is highly unusual. It only happens when findings are so overwhelmingly positive.
Right, it would be unethical to continue.
Exactly. The reason it was stopped, the group of patients treated to a systolic blood pressure target of 120 millimillimeter G experienced a remarkable 25% lower rate of major cardiovascular events and total mortality compared to the group targeted to 140 millimilli Hg. That's just a massive difference in life and death outcomes.
Wow, 25% lower mortality rate is huge.
Mm.
Were there any downsides, any additional risks that came with this intensified treatment?
There were, yeah, and it's important to acknowledge them for a balanced picture. The intensified treatment group did experience higher rates of certain adverse effects, things like hypotension, blood pressure dropping too low, and some worsening of kidney function. However, the study's conclusion was crucial. These adverse effects did not translate to what they called a signal for real harm, meaning that despite these challenges, these substantial benefits reducing cardiovascular events, reducing mortality, were deemed to clearly outweigh these manageable risks.
So how did this, and other research like it, influence the major guidelines that doctors use today?
Well, the profound consequences of SPRINT, alongside other research, led to new guidelines from major bodies like the American Heart Association, American College of Cardiology, AHACC, and the European Society of Cardiology, ESC. You now see slightly differing thresholds. In the U.S., hypertension is now defined as a blood pressure of 30-80 millimilli Hg or higher. In Europe, it's set a bit higher, at 490 milli Hg or higher. These criteria are specifically designed to identify patients whose risk of hypertension-related cardiovascular disease is high enough to warrant immediate medical attention.
So it's not just a simple cutoff point then, where you're either hypertensive or you're not. It sounds more like a spectrum.
Exactly, that's a crucial point. It's not just about these binary thresholds. The risk of both fatal and non-fatal cardiovascular disease in adults is actually lowest with systolic pressures below 120 and diastolic below 80. What this means is that these risks increase incrementally, continuously, as systolic and diastolic pressures rise. It really demonstrates that hypertension is a spectrum of risk, not some simple on-off switch. Even levels we used to call pre-hypertension carry an increasing risk profile.
Interesting. So which numbers are considered more important today? The top number, systolic, or the bottom number, diastolic? Has that thinking changed?
That's a great question, and yes, our understanding has definitely shifted there too. While many early clinical trials focused heavily on diastolic pressure for classifying severity, it's now abundantly clear that progressive elevations of systolic pressure are similarly, if not more, predictive of adverse cardiovascular events. In fact, in patients over 50 years old, systolic blood pressure actually predicts adverse outcomes better than diastolic pressure does. This has really changed how we assess risk.
That's quite a distinction. I've also heard about something called pulse pressure. What's its role in all of this? Is that important too?
Yeah, digging a bit deeper, pulse pressure, which is simply the difference between your systolic and diastolic pressure, can add additional predictive value. A higher than normal pulse pressure can indicate adverse remodeling of blood vessels. Essentially, it represents an accelerated decrease in blood vessel flexibility, or stiffening, which is normally associated with aging and atherosclerosis, or hardening of the arteries.
Yeah.
We see this particularly with a condition called isolated systolic hypertension, or ISH. That's where the systolic pressure is high, but the diastolic pressure is normal. In younger people, particularly men, ISH is strongly linked to smoking. In elderly people, it's a clearer indicator of that stiffening of the large arteries, reflecting cumulative vascular damage.
Does having other health issues, comorbidities, significantly impact the prognosis for someone with hypertension?
Oh, absolutely. Profoundly so. High blood pressure in the presence of damage in certain target organs signals a much, much worse prognosis than the same blood pressure level in someone without those findings. For instance, if a patient has damage in their eyes, retinal hemorrhages, exudates their short-term prognosis is far worse for a given BP level. Similarly, left ventricular hypertrophy thickening of the heart muscle is associated with a substantially worse long-term outcome, including a higher risk of sudden cardiac death.
And other risk factors.
Yes, the risk is also markedly increased by things like cigarette smoking, diabetes, or high LDL cholesterol, the bad cholesterol. The coexistence of hypertension with these risk factors actually compounds the cardiovascular risk. Each additional factor doesn't just add to the danger, it significantly amplifies it.
Right, a multiplier effect. So considering all these factors, what's the ultimate goal of all this treatment then? What are we really trying to achieve?
The fundamental purpose of treating hypertension is quite clear. It is to fundamentally decrease cardiovascular risk and, by doing so, improve life expectancy. Effective pharmacological treatment clearly decreases morbidity and mortality from cardiovascular disease. It particularly reduces the risk of stroke, heart failure, and coronary artery disease. Interestingly, the reduction in the risk of heart attack might be a bit less significant compared to those other outcomes, but the overall benefit for extending a healthy life is absolutely undeniable.
Now that we understand the gravity of hypertension and its widespread impact, let's talk about how we actually treat it. Where do we begin when a patient is diagnosed?
The very first and absolutely crucial step for all patients with hypertension is non-pharmacological therapy, lifestyle changes. This foundation is so important that in some people with grade 1 hypertension, that's systolic 130/139, or diastolic 80/89 blood pressure, might even be adequately controlled solely by these methods, potentially avoiding or at least delaying the need for medication altogether.
What are these specific lifestyle modifications? What kind of habits are we talking about? Give us the rundown.
Yeah, it's a comprehensive set of healthy habits. First, achieving weight loss if you're overweight or obese. Second, a significant reduction in sodium intake, less than 5 grams of salt per day. Third, increasing aerobic exercise, aiming for more than 30 minutes per day on most days. Fourth, moderating alcohol consumption. That usually means no more than 2 standard drinks per day for men and 1 for women.
Okay.
Fifth, and this is critical, smoking cessation. Absolutely essential. And finally, eating a balanced, heart-healthy diet, increased consumption of fruits, vegetables, and low-fat dairy products. These are truly foundational.
That's a solid foundation, definitely healthy habits. But the reality is, many patients eventually need medication, right? What happens when lifestyle changes alone aren't enough?
You're right. The majority of patients will eventually require drug therapy for adequate blood pressure control. And while current guidelines from various cardiovascular societies might differ slightly in their precise definitions or targets, the core principles of drug therapy remain remarkably consistent across the board.
And what's one of the most important common recommendations in terms of how we approach starting drug therapy?
One of the most important recommendations now is the early use of single pill combination therapy for many patients, especially for those whose blood pressure is significantly above their target goal, say more than 20/10 millimillig above. This approach, combining multiple mechanisms in one pill, often significantly improves both patient adherence, easier to take one pill than 2 or 3, and overall efficacy. It's a very pragmatic and effective strategy.
Makes sense. So how do these medications actually work? What are the underlying physiological mechanisms they target inside the body to lower blood pressure?
Okay, to understand how these drugs work, we need to remember a fundamental principle. Arterial pressure is ultimately the product of 2 main factors: cardiac output, how much blood the heart pumps per minute, and peripheral vascular resistance, basically, how constricted or relaxed your blood vessels are. Essentially, drugs lower blood pressure by acting on one or both of these, either reducing peripheral resistance or reducing cardiac output, or sometimes both. For example, drugs can decrease cardiac output by inhibiting how hard the heart muscle pumps, or by reducing the pressure that fills the heart's ventricles before it pumps. Reducing that filling pressure can happen by relaxing your veins, or by reducing your overall blood volume through effects on the kidneys, making you excrete more fluid.
Okay, that's the cardiac output side. What about resistance?
Right. Drugs can decrease peripheral resistance by directly relaxing the smooth muscle in your artery walls, allowing them to widen or dilate. Or they can interfere with the activity of the body's natural systems that cause blood vessel constriction, like the sympathetic nervous system or the renin-angiotensin system, which we'll talk more about.
And we often hear about the importance of sodium. How does lowering body sodium connect to these mechanisms? It's not just about fluid, is it?
No, it's more complex. Lowering body sodium, either through diuretics or a low-salt diet, can indirectly lower peripheral resistance. This might happen by reducing the body's sensitivity to vasoconstrictors, the chemicals that narrow blood vessels. And interestingly, by reducing a specific type of inflammation involving T cells, that's a newer insight, showing sodium's role goes beyond just fluid balance. Also, in patients with isolated systolic hypertension, where the arteries are stiff, drugs might work partly by improving the flexibility of those large arteries too.
That's a fantastic overview. Does this imply that drugs from different classes often work well together, hitting different mechanisms?
Precisely. Antihypertensive drugs are classified by their specific targets or mechanisms. Understanding these provides a strong rationale for using two or more drugs concurrently. This approach, combining agents from different classes, is a really smart strategy. It achieves effective blood pressure control while minimizing dose-related side effects. You get additive benefits in lowering blood pressure without necessarily increasing the side effects you'd get from pushing one drug to a very high dose. It's all about synergy.
Given how common hypertension is, can we reliably predict how an individual patient will respond to a specific drug? Is there a way to know beforehand?
Yeah, that's a really important question, and one patients often ask. Unfortunately, it's generally not possible to predict an individual's response to a specific drug with high accuracy. For example, for some common antihypertensives, about two-thirds of patients will have a meaningful clinical response, but about one-third just won't respond well to that same drug. There's a lot of variability.
Are there any general population-level clues, like age or ethnicity?
Well, broad categories like racial origin and age might have a modest influence on the likelihood of a favorable response to a particular class of drugs. For instance, some groups tend to respond a bit better to certain diuretics or calcium channel blockers, but it's generally not a strong enough predictor for an individual patient. And pharmacogenetics, studying how genes affect drug response, has identified differences in drug metabolism. Some people break down certain drugs much slower.
Ah, so genetics matters.
It matters for how much drug is in the system, yes. But interestingly, the differences in efficacy, how well the drug actually lowers blood pressure, are often much smaller, and the clinical relevance for prediction is still largely unknown. So, while we know genetics plays a role in drug processing, it doesn't give us a crystal ball for predicting an individual's blood pressure response, unfortunately. Not yet, anyway.
Okay, so despite all these individual variations in genetic influences, what's the ultimate guiding principle for treatment? What's the main goal?
While individual responses vary, it's firmly established that the primary goal in treating hypertension is the sustained reduction in mean blood pressure itself. That's the overarching principle. However, differences between drug classes can still be relevant, particularly concerning side effects, how easy it is for patients to stick to the regimen, specific benefits for other coexisting diseases, and most importantly, their overall efficacy in improving crucial cardiovascular outcomes like preventing strokes or heart failure. So current guidelines broadly differentiate between several categories. We have the first-line antihypertensives, ACE inhibitors, ARBs, calcium channel blockers, and diuretics. These are the workhorses, used alone or in combination. Then there are second-line drugs, spironolactone, beta blockers, alpha-1 blockers. And finally, some antihypertensives are reserved for special indications, like during pregnancy or for patients with terminal kidney failure. This kind of tiered approach helps clinicians navigate the options.
Okay, let's get into the specifics of these drug classes. Let's start with what you mentioned are among the most frequently prescribed worldwide inhibitors of the renin-angiotensin system, or RAS. This sounds like a really fundamental body system.
It absolutely is. The renin-angiotensin system is a critical hormonal system. It finely regulates blood pressure and fluid balance throughout the body. Angiotensin II, or Ang, is a key hormone in this system. It's a powerful constrictor of blood vessels, and it also promotes fluid retention. So the ability to reduce its effects with drugs has been a monumental advance in treating hypertension and its consequences.
Let's start with the first group. Angiotensin-converting enzyme inhibitors, or ACE inhibitors. How do they work, and what are their main benefits?
Right. ACE inhibitors function by reducing the levels of Ang. They do this by blocking the enzyme angiotensin-converting enzyme that converts angiotensin I into the active angiotensin II. Captopril was the first one. Then came others like enalapril, lisinopril, ramipril. You've probably heard of some of these. They're highly valued because they're effective and generally have a favorable side effect profile, which really helps patients stick with long-term therapy. That's huge in chronic disease.
And are there specific patient groups who benefit most?
Yes, a significant advantage is their protective effect on the kidneys, especially in patients with diabetes. They can slow the development and progression of diabetic kidney disease. They also help in other forms of chronic kidney disease. So for these patients, an ACE inhibitor is often the preferred initial choice. They're also very beneficial for patients with hypertension and coronary artery disease, especially after a heart attack. They can improve heart function and reduce complications and mortality there.
How do ACE inhibitors interact with diuretics? They both affect fluid balance, right? And what about potassium levels? That's often mentioned.
Good questions. ACE inhibitors and diuretics work really well together synergistically. By blunting the rise in aldosterone, that hormone causing sodium and water retention, ACE inhibitors significantly enhance the efficacy of diuretics, meaning even low doses of a diuretic can have a much greater blood pressure lowering effect when combined with an ACE inhibitor.
But there's a flip side.
Right. This interaction means careful monitoring is needed. High doses of diuretics with ACE inhibitors can lead to excessive blood pressure drops and sodium loss in some people. Regarding potassium, ACE inhibitors tend to cause a small, usually clinically unimportant increase in potassium levels. This is because they reduce aldosterone. But this can become problematic in patients with kidney impairment or when combined with other potassium-retaining drugs like certain diuretics, NSAIDs, or potassium supplements. This risk of high potassium, hyperkalemia, is particularly important to watch for in patients with diabetic kidney disease.
Are there any critical cautions or adverse effects listeners should really be aware of with ACE inhibitors?
Yes, definitely several key points. A common side effect, affecting maybe 5% or so of patients, is a persistent dry cough. It's often described as irritating.
Ah, yes, the ACE inhibitor cough.
Exactly. And it's a frequent reason people get switched to an ARB, which we'll discuss. Then there's angioedema. It's rare, but very serious, potentially life-threatening. It involves sudden, severe swelling, usually of the face, tongue, airways. Patients must be explicitly warned to stop the drug immediately and seek help if they notice any swelling like that.
That sounds critical.
It is. And another critical point, ACE inhibitors are absolutely contraindicated during pregnancy. They can cause severe fetal harm. This is a vital warning for all women of childbearing age. Finally, in patients with severe narrowing of the kidney arteries, ACE inhibitors can sometimes cause a significant drop in kidney function, so kidney function must be closely monitored when starting therapy.
Okay, let's move on to the next class within RAS inhibitors.
Yeah.
AT1 receptor blockers, or ARBs. How do they compare to ACE inhibitors?
ARBs, like losartan, valsartan, candesartan, they work a step later in the pathway. They block the specific receptor, the AT1 receptor, where angiotensin II actually binds to exert its effects. So they effectively prevent angina from constricting blood vessels and promoting fluid retention. They achieve very similar blood pressure lowering effects to ACE inhibitors.
And the key difference?
The key advantage, and why many patients prefer them or get switched, is that they do not cause the cough that ACE inhibitors can. This is because ARBs don't interfere with the breakdown of a substance called bradykinin, which is thought to contribute to the cough mechanism with ACE inhibitors.
Right. There was some early hope, wasn't there, that ARBs might actually offer more benefits than ACE inhibitors. Did that pan out?
Yeah, initial hopes were high. The theories involved potential benefits from stimulating a different angiotensin receptor, the AT2 receptor. However, large, well-conducted trials, like the important On-Target study, showed that while ARBs were effective and caused less cough and angioedema than ACE inhibitors.
Which is good.
Right, definitely good from a side effect perspective. But they had identical efficacy in preventing major cardiovascular events. No superiority found. And crucially, the study also looked at combining an ARB with an ACE inhibitor. Surprisingly, this combination did not offer additional benefits, but instead led to more adverse effects, things like worsening kidney function, more hypotension, and fainting.
So the takeaway is definitely no combination of ACE inhibitors and ARBs then.
That's correct. Based on current evidence, the combination of an ACE inhibitor and an ARB is not recommended for treating hypertension. It seems to cause more harm than good. Most ARBs are effective with once-daily dosing, though the full blood pressure effect can take about 4 weeks to fully develop. If an ARB alone isn't sufficient, the appropriate next step is adding a drug from a different class, like a diuretic or a calcium channel blocker. And ARBs have a similar safety profile to ACE inhibitors regarding risks of low blood pressure, high potassium, effects on kidney function, and they are also strictly contraindicated in pregnancy. Same warning applies.
Okay, let's touch on the third type of RAS inhibitor, direct renin inhibitors, or DRIs, with aldosterone being the main example. How does this one fit into the picture?
Allosterone is unique because it acts right at the very beginning of the renin-angiotensin system cascade. It directly inhibits the enzyme renin itself. This directly reduces the production of angiotensin I and subsequently angiotensin II and aldosterone, leading to a fall in blood pressure. An interesting point is that while it causes renin levels in the blood to increase adaptively, like ACE do, it uniquely inhibits renin activity. However, similar to ACE inhibitors and ARBs, it can still experience that phenomenon of aldosterone escape, where aldosterone levels might creep back up over time.
So, given how it targets the RAS system at the top, how should aldosterone be used? Are there any critical contraindications we need to know?
Well, the role of allosterone as a standalone treatment has remained somewhat unclear, actually. A large study back in 2012 looked at adding allosterone to patients already on an ARB or ACE inhibitor. That study was stopped early.
Why was that?
Because there was a concerning trend toward increased cardiovascular events in the allosterone group, along with more kidney worsening, low blood pressure, and high potassium. This really reinforces the principle we saw with the ACE-IRB combo, that attempting a complete blockade of the RAS system often seems to result in more harm than benefit. Therefore, based on this evidence, the combination of allosterone with other RAS inhibitors like ACE inhibitors or ARBs is absolutely contraindicated.
Wow, another strong contraindication.
Yes. Allosterone itself is generally well tolerated, though diarrhea can occur at higher doses. And it shares the same critical warning as all RAS inhibitors. It must not be used during pregnancy due to potential fetal harm.
Okay, so while RAS inhibitors are clearly powerful tools, they come with significant nuances and really specific contraindications, especially around combinations in pregnancy. Let's shift gears now to calcium channel blockers, or CCBs.
Right. CCBs are another incredibly important and widely used group of drugs for managing hypertension. Hypertension, as we said, is often characterized by increased peripheral vascular resistance. Your blood vessels are more constricted. Since the contraction of that vascular smooth muscle depends on calcium moving into the muscle cells, CCBs work by blocking this movement of calcium through specific voltage-sensitive channels. This action directly relaxes the muscle and the artery walls, causing vasodilation, widening the vessels, and therefore decreasing peripheral vascular resistance.
Do CCBs cause any compensatory changes, like in heart rate? And are there different types of CCBs we should be aware of?
Yes, a decrease in peripheral resistance can trigger the body's natural reflex to increase heart rate, the baroreceptor reflex. With one type of CCB, called dehydropyridines, think amlodipine, you might see a slight increase in heart rate, though it's usually pretty modest unless the drug is given rapidly. However, other CCBs, specifically verapamil and diltiazem, actually have a direct effect on the heart's pacemaker, slowing the heart rate, so they cause minimal or no tachycardia.
And that difference matters clinically.
It matters significantly because it means the concurrent use of beta blockers, which also slow the heart rate, with verapamil or diltiazem, should generally be avoided. That combination can potentially magnify the negative chronotropic effects, dangerously slowing the heart or even causing heart block in susceptible patients. A key interaction to remember.
Okay, what about their clinical effectiveness and how they fit into combination therapies? Are they considered first line?
Yes, CCBs are definitely among the preferred drugs for hypertension, both as monotherapy and in combination therapy. They have a well-documented positive effect on preventing major cardiovascular events and reducing overall mortality. Large trials have shown this. For example, studies like ASCOT showed that combinations involving the CCB amlodipine and an ACE inhibitor were superior to other common drug combinations, like a beta blocker plus a diuretic.
So which CCBs are most commonly used? And what about side effects?
The most studied and widely used CCBs for hypertension are the long-acting dihydropyridines, like amlodipine or felodipine, often in sustained-release formulations. These are great because they typically provide sufficient 24-hour efficacy with just once daily dosing, which is excellent for patient adherence. The main unwanted effect people notice with these is peripheral edema, particularly ankle swelling. It's generally harmless but can be quite bothersome for some patients.
Are there CCBs to avoid?
Yes. It's important to note that immediate-release nifedipine and other short-acting dihydropyridines have no place in routine hypertension treatment. They can cause rapid blood pressure drops and significant reflex tachycardia. Verapamil and diltiazem also have shorter half-lives, more potential cardiac side effects, and more drug interactions, so they aren't usually first-line choices for hypertension either.
And do CCBs work particularly well for certain patient populations?
Yes, there's evidence they can be particularly effective as a first choice or monotherapy in older patients and in African Americans. These are population groups where a lower renin status is often more prevalent, and CCBs don't rely on the renin system. They are also very effective in lowering blood pressure and decreasing cardiovascular events in elderly patients who have isolated systolic hypertension. They can be a preferred treatment in these patients. But as always, it's crucial to remember that individual patient response can vary significantly, so personalization remains absolutely key.
Okay, let's move on now to diuretics. You mentioned they have a long and important history in blood pressure management.
They absolutely do. Historically, one of the very earliest strategies for managing high blood pressure was simply restricting dietary salt, a very basic approach. The development of orally active thiazide diuretics, though, marked a major practical pharmacological advancement. It made the sodium balance approach much more feasible and effective. And this class of drugs remains absolutely crucial today. Why? Because they not only have significant blood pressure lowering effects on their own, but they also notably enhance the efficacy of nearly all other antihypertensive drugs. They are truly a cornerstone in combination therapy.
How exactly do diuretics, especially the thiazides, work to lower blood pressure in the long term? It sounds like it's more complex than just, making you urinate more.
You're absolutely right. The long-term mechanism is quite intricate and honestly still debated beyond their initial fluid-reducing effects.
Yeah.
Initially, yes, thiazide diuretics increase sodium and water excretion from the kidneys by blocking a specific transporter in the distal tubule. This leads to an immediate decrease in blood volume and thus cardiac output.
But that changes over time.
Exactly. During long-term therapy, blood volume and cardiac output tend to return towards normal levels due to various compensatory mechanisms in the body. Yet the blood pressure lowering effect is maintained. This sustained effect is thought to be due to a decrease in peripheral vascular resistance. How does that happen? Well, this long-term vasodilation is likely an indirect consequence of their kidney action, perhaps by reducing the sensitivity of blood vessels to constricting signals. Or, and this is a newer idea, by influencing how sodium is stored non-osmotically in the body's tissues, like skin and muscle, which can impact inflammation and vessel stiffness. It's complex.
That is intricate. So what are the most commonly used diuretics in this class? And are there important differences in their effectiveness?
The most frequently used are the thiazides and related compounds, like hydrochlorothiazide, often called HCTZ, chlorthalidone, and indapamide. While they share similar pharmacological effects, their pharmacokinetics, how the body processes them, differ, and this significantly impacts their clinical efficacy. For instance, in direct comparisons, chlorthalidone has been shown to have greater blood pressure lowering efficacy than hydrochlorothiazide, especially during the night.
Why is that?
It's likely because chlorthalidone has a much, much longer half-life. It stays active in your system for well over 24 hours compared to just several hours for hydrochlorothiazide. This leads to more stable, consistent blood pressure reductions throughout the entire day and night. Meta-analyses have confirmed chlorthalidone's superiority in long-term studies, suggesting it might actually be an underutilized drug.
That's a really important practical difference. What about dosing for these diuretics? Is always better?
No, definitely not. Many patients achieve excellent blood pressure control with quite low daily doses, like 12.5 milligrams of chlorthalidone or hydrochlorothiazide. For most patients with normal kidney function, exceeding 25 milligrams daily of hydrochlorothiazide or chlorthalidone equivalent generally doesn't provide much additional blood pressure lowering. But it significantly increases the risk of side effects, particularly potassium loss, and increased uric acid levels, which can trigger gout.
So higher doses are riskier.
Yes. In fact, studies have shown that higher diuretic doses, especially if the resulting low potassium isn't corrected, are associated with an increased risk of sudden cardiac death. So the clear recommendation is, if 25 milligrams daily doesn't achieve adequate blood pressure reduction, adding a second drug from a different class is almost always preferred over simply increasing the diuretic dose.
What about combining them with other drugs, especially given that concern about potassium loss?
Urinary potassium loss is a common and potentially serious issue with thiazides. This is where combining them with ACE inhibitors, or ARBs, becomes particularly rational and beneficial. As we discussed, those RES inhibitors can help mitigate the potassium loss caused by the diuretic. It's a very sensible combination.
But you still need to be careful.
Absolutely. When combining, it's essential to start with low doses of each drug. And combining potassium-sparing agents with each other, or with potassium supplements, requires great caution due to the risk of potentially dangerous hyperkalemia hypotassium. It's also worth noting that for severe or resistant hypertension, which isn't responding well to 3 or more other drugs, higher doses of thiazides or even stronger loop diuretics like furosemide might sometimes be necessary. In those cases, blood pressure can become very dependent on fluid volume.
Can you summarize the most important adverse effects and maybe key drug interactions for diuretics? Sounds like there are quite a few.
Yes, definitely. The most critical adverse effect, the one we keep mentioning, is potassium depletion or hypokalemia. This is dose-dependent and is a serious risk factor for dangerous heart arrhythmias, including a specific type called torsade de pointe and an increased risk of sudden cardiac death. This is why hypokalemia must be carefully avoided, ideally by combining thiazides with RAS inhibitors or specific potassium-sparing diuretics.
What else should people be aware of?
Other notable side effects include erectile dysfunction, which physicians should specifically ask about as patients might be hesitant to mention it. They can also raise uric acid levels, potentially precipitating gout, though this is less common at the recommended low doses. Hyponatremia, or dangerously low sodium levels, can sometimes occur rapidly, especially with hydrochlorothiazide in certain susceptible individuals. Thiazides can also cause hypercalcemia, high calcium, by reducing how much calcium is excreted by the kidneys. This can actually be beneficial for patients with osteoporosis, but problematic in others. And as mentioned, recent data suggests an increased risk of certain non-melanoma skin cancers with long-term hydrochlorothiazide use, likely due to photosensitization. A warning now required on label.
Interactions.
Diuretics' antihypertensive effects are boosted by most other classes, which is why they're great in combinations. But they can potentiate arrhythmias if combined with digoxin, especially if potassium is low. Their effects can be blunted by NSAIDs, like ibuprofen, and all diuretics can increase lithium levels, requiring careful monitoring in patients taking lithium.
Wow, so many interactions and considerations. Okay, let's shift gears again. Let's talk about sympatholytic agents. Where do they fit in, especially the well-known beta blockers?
Sympatholytic agents, drugs that interfere with the sympathetic nervous system, the body's fight or flight system, have a long history in hypertension treatment. Beta blockers were actually first investigated for angina, chest pain. It was an unexpected finding that they also lowered blood pressure. Pronetholol was the first, but propranolol was the one that really established the class.
How exactly do beta blockers lower blood pressure? And what are the important distinctions between the different types of beta blockers available?
Beta blockers work primarily by reducing the heart's workload. They slow the heart rate and reduce the force of the heart's contractions, which decreases cardiac output. They also act on the kidneys to reduce the secretion of renin, which, as we know, dampens down the whole renin-angiotensin system. Now, different beta blockers have varying properties. Some are more selective for the beta-1 receptors found mainly in the heart, like metoprolol or bisoprolol. Others block beta-1 and beta-2 receptors more broadly, like propranolol. Blocking beta-2 receptors can lead to more side effects like bronchoconstriction or issues with blood sugar. Some beta blockers, like carvedilol or labetalol, also have additional alpha-blocking effects, which helps relax blood vessels directly. And nabivolol promotes nitric oxide release, another way to vasodilate.
So these differences matter.
They do, mainly for side effects and specific patient situations. While all are effective antihypertensives, these differences impact their clinical use. Also, pharmacokinetically, many beta blockers have relatively short half-lives and ideally need to be given more than once daily or prescribed in sustained release forms for convenient once-daily dosing and better compliance.
How has our understanding of beta blockers' effectiveness in hypertension specifically changed over time? It seems their role has shifted in the guidelines.
Yes, that's true. Meta-analyses looking at many studies together suggested that while beta blockers reduce the incidence of heart attacks similarly to other major drug classes, they seem to be only about half as effective in preventing stroke. This finding was quite significant and led to their general downgrading in major hypertension guidelines as first-line therapy for uncomplicated hypertension.
Is that a definite class effect or related to specific drugs used in older studies?
That's been debated. It's argued that many of the key supporting studies predominantly used atenolol, which might not be the ideal beta blocker for various reasons. Atenolol, unlike newer agents like bisoprolol, carvedilol, or metoprolol, hasn't performed as well in heart failure trials, for instance. It might not lower central aortic blood pressure as effectively as peripheral pressure. Whether other beta blockers are truly better in these aspects isn't definitively proven without head-to-head trials. Regardless, beta blockers as a class are generally associated with more side effects than ACE inhibitors, ARBs, or calcium channel blockers, things like fatigue and an increased incidence of developing new-onset diabetes and weight gain. Therefore, beta blockers are now primarily recommended only in patients who have a specific, compelling indication for their use, like established heart failure, previous heart attack, or certain arrhythmias, or perhaps as a third-step therapy when other drugs aren't sufficient.
Okay, that clarifies their current place. What are the key adverse effects and precautions people need to be aware of with beta blockers?
Right. They should generally be avoided or used with extreme caution in patients with reactive airway disease like asthma, because blocking beta 2 receptors can worsen bronchospasm. Also, caution is needed in patients with certain heart rhythm problems involving the SA or AV node, especially if combined with other drugs that slow conduction, like verapamil. They can mask some symptoms of hypoglycemia, low blood sugar, in diabetics taking insulin, although type 2 diabetes itself isn't usually a contraindication anymore. They can also affect lipid profiles, increasing triglycerides and lowering HDL cholesterol, though the long-term impact of this is unclear. And they might aggravate depression or psoriasis in some individuals.
And you mentioned withdrawal.
Yes, a critical precaution is the withdrawal syndrome. Suddenly stopping beta blockers, especially after long-term use, can cause a severe rebound effect. This is likely due to the body's beta receptors becoming upregulated or more sensitive during the blockade. When the drug is stopped, the body overreacts to its own adrenaline. This can worsen angina, cause dangerous arrhythmias, and lead to rebound hypertension. Therefore, beta blockers should never be stopped abruptly. The dosage must be tapered gradually, usually over 10 to 14 days, under close medical supervision. Also, a specific interaction. Epinephrine, like in EpiPens or dental anesthetic, can cause severe hypertension and bradycardia if given to someone on a non-selective beta blocker due to unopposed alpha receptor stimulation.
Let's move on to alpha-1 blockers. How do they work, and what's their current role in hypertension?
Alpha-1 blockers like prazosin, terazosin, or doxazosin work by selectively blocking alpha-1 adrenergic receptors located on blood vessels. This prevents adrenaline and noradrenaline from constricting the vessels, leading to vasodilation. They initially reduce arterial resistance and also increase the capacity of veins, which can cause a reflex increase in heart rate early on. Long-term, the vasodilation persists.
Are they used often?
They are not recommended as monotherapy for hypertension. This is primarily due to findings from a large study called ALHAT. In ALHAT, patients randomized to the alpha blocker doxazosin as initial therapy had a significantly higher risk of developing congestive heart failure compared to those started on a diuretic.
So not first line or alone. Where are they used then?
They are mainly used in combination with other drugs, like diuretics or beta blockers. Beta blockers can actually enhance their efficacy. However, they have a particularly useful niche. They are quite effective for hypertensive patients who also have symptomatic benign prostatic hyperplasia, or BPH. They improve urinary flow symptoms, offering a valuable dual benefit in those specific patients. A key side effect to warn patients about is the first dose phenomenon. This is where symptomatic orthostatic hypotension, dizziness, or fainting upon standing can occur within an hour or two of the very first dose, or after a dose increase. It can be quite pronounced, especially if the patient is already on a diuretic. Tolerance usually develops quickly, though.
Okay. Now, what about drugs that combine alpha and beta blockade, like carvedilol and labetalol?
These offer a dual mechanism in a single molecule. Carvedilol, for instance, is a non-selective beta blocker that also possesses alpha-1 antagonist activity. It's approved for both hypertension and, importantly, for symptomatic heart failure. It has been shown to reduce mortality in patients with congestive heart failure, making it a key drug in that setting. Its vasodilating effect also makes it potentially a better choice than some other beta blockers for patients who also have peripheral artery disease.
And labetalol.
Labetalol is another combined alpha-1 and beta blocker. It's actually a mixture of different isomers with different activities. While effective, the relative extent of its alpha-1 versus beta blockade can be somewhat unpredictable and vary between patients, which is a potential downside of fixed combos. Labetalol is notably FDA approved for hypertensive emergencies, particularly for managing severe hypertension during pregnancy, like eclampsia and preeclampsia. It's considered one of the safer options in that specific situation.
Let's turn now to centrally acting sympatholytic drugs. These sound like they work in the brain. Let's start with methyltepro.
Yes, these drugs reduce sympathetic outflow from the central nervous system. Methyldopa historically was frequently used, but its adverse effect profile means its use now is largely limited to treating hypertension during pregnancy, where it has a long and established record for safety for both mother and fetus. It's actually a prodrug. It gets converted in the brain into its active form, alpha-methylnorepinephrine. This active metabolite then acts on specific alpha-2 receptors in the brainstem to decrease the sympathetic signals going out to the blood vessels, thus lowering blood pressure.
What are its main adverse effects that limit its broader use today? Why isn't it used more generally?
The main limiting factors are its CNS side effects. Sedation is very common, especially initially, and a persistent diminution in psychic energy or concentration can occur. More seriously, it can occasionally cause psychotic depression, which can be severe and may appear insidiously over weeks or months, making it hard to recognize initially. Therefore, methyldopa must be discontinued at the first sign of depression, and critically, it should never be given to patients with a history of depression.
That's a major warning. Any other significant side effects?
Other effects can include dry mouth, diminished libido, Parkinsonian signs in some people. Rarely, it can affect the liver or cause specific immunological or hematological problems like a positive Coombs test or even hemolytic anemia, though these are less common at typical doses used in pregnancy.
Okay. What about clonidine? It's another centrally acting agent, right?
Yes, clonidine works similarly by stimulating alpha-2A adrenergic receptors in the brainstem, which reduces overall sympathetic outflow from the CNS, lowering blood pressure. While it can be effective in lowering blood pressure, particularly in some patients unresponsive to other combinations, its use is limited by a couple of key factors. One is a lack of robust, large-scale trial evidence showing that it definitively reduces the long-term cardiovascular consequences of hypertension, like heart attacks or strokes, compared to other major drug classes.
And the other limiting factor?
Side effects, again, primarily CNS effects. Prominent sedation and xerostomia, dry mouth, are very common and can be persistent and intolerable for many patients. Postural hypotension and erectile dysfunction can also occur. And, just like beta blockers, clonidine carries a significant risk of a severe withdrawal syndrome if stopped abruptly.
The rebound effect again.
Exactly. Suddenly stopping clonidine can cause headache, anxiety, tremors, sweating, a rapid heart rate, and a potentially dangerous surge in blood pressure, sometimes well above the pretreatment levels. This rebound is due to a sudden increase in sympathetic nervous system activity.
How is this withdrawal syndrome managed, especially if it's urgent?
If it's not immediately life-threatening with organ damage, simply restarting the clonidine is the best approach. For rapid emergency control, other intravenous drugs might be used. Crucially, just like with beta blocker withdrawal, other beta blockers should not be used alone in this setting. They can actually worsen the high blood pressure by blocking vasodilation while leaving alpha-mediated constriction unopposed from all the excess adrenaline. All patients on clonidine must be warned about the danger of abrupt discontinuation, and it should probably be avoided in patients suspected of being non-compliant with medications.
So reserpine, you mentioned earlier, is more of a historical note now.
Yes, reserpine is largely historical in most parts of the world. It was one of the very first effective antihypertensives, working by depleting norepinephrine from nerve endings. However, like methyldopa, it has significant CNS side effects, most notably the risk of inducing severe insidious depression, potentially leading to suicide. It's generally not recommended for hypertension treatment anymore, given the availability of safer, better tolerated, and more proven alternatives.
Okay, understood. Let's move to the vasodilator class now. What about hydralazine?
Hydralazine is another older drug, one of the first orally active antihypertensives. Its use significantly diminished over time due to prominent side effects like reflex tachycardia, fast heart rate, and tachyphylaxis, losing effectiveness over time. It worked by directly relaxing the smooth muscle in arterioles, the small arteries, with little effect on veins. The exact mechanism isn't fully clear, but likely involves calcium regulation within the muscle cells. The problem is, this powerful vasodilation strongly stimulates the sympathetic nervous system via baroreceptor reflexes. This leads to increased heart rate, increased heart contractility, activation of the renin system, and fluid retention, all of which counteract its blood pressure lowering effect.
So what are its key uses and side effects today, given those limitations?
Hydralazine is definitely no longer a first-line drug due to that unfavorable side effect profile. It does have a specific role in a combination pill with isosorbide dinitrate called Badil, which is approved specifically for treating heart failure in African American patients. It might occasionally be useful in some severe or resistant hypertension cases, always in combination with drugs to block the reflex effects, like a beta blocker and a diuretic. It's also still used sometimes in hypertensive emergencies, especially preeclampsia in pregnant women.
What are the main safety concerns?
A major concern, especially in patients with underlying coronary artery disease, is the risk of precipitating myocardial ischemia or even a heart attack due to the reflex tachycardia, increasing the heart's oxygen demand. The other notable unique adverse effect is a drug-induced lupus syndrome. This is an autoimmune-like reaction that typically occurs after at least 6 months of continuous treatment, is dose-related, and more common in women and Caucasians. If symptoms like joint pain, fever, or arthritis appear, the drug must be stopped.
Okay. Next, let's explore minoxidil. This one sounds familiar, maybe not just for blood pressure.
Right, minoxidil is probably more famous now as the active ingredient in Rogaine, used topically for hair loss. But systemically, taken orally, it's an extremely potent vasodilator. It's typically reserved for severe, refractory, or drug-resistant hypertension that hasn't responded to multiple other medications. It's actually a prodrug that gets converted to its active form, which then works by opening specific ATP-modulated potassium channels, KATP channels, in vascular smooth muscle cells. This causes potassium to flow out, hyperpolarizing the cell and leading to profound relaxation and dilation primarily of arterioles.
So, being that potent, what are the crucial considerations when using oral minoxidil?
The absolute crucial point is that minoxidil should never, ever be used alone. It causes such strong reflex sympathetic activation and profound fluid retention. It must be given concurrently with an adequate diuretic, often a potent loop diuretic like furosemide, especially if kidney function is impaired, to prevent severe edema and potential heart failure. And it must also be given with a sympatholytic drug, usually a beta blocker, to control the reflex tachycardia, increased heart contractility, and renin release. Often an ACE inhibitor or ARB is added too.
What are its main side effects besides those reflex issues?
Besides the fluid retention and cardiovascular effects, which can be severe if not properly managed with concurrent drugs, the most characteristic side effect is hypertrichosis. This is excessive hair growth, often quite noticeable on the face, back, arms, and legs. It occurs with extended use and is particularly bothersome for women. It's likely related to the potassium channel activation. It usually requires cosmetic management like shaving or depilatories. Minoxidil is also contraindicated in patients with pheochromocytoma, a type of adrenal tumor.
Finally, let's briefly touch on sodium nitroprusside. This is mainly for emergencies, right?
Exactly. Sodium nitroprusside is a fast-acting, extremely potent vasodilator that's administered intravenously, almost exclusively for managing hypertensive emergencies in a hospital setting. It works by releasing nitric oxide, NO, directly in the bloodstream. NO then activates pathways within smooth muscle cells that lead to profound relaxation of both arterioles and venules. Its effect starts within 30 seconds and disappears within 3 minutes of stopping the infusion, which allows for very precise minute-to-minute control of blood pressure in critical situations like hypertensive encephalopathy or aortic dissection.
And what are its most important safety concerns given its potency in emergency use?
The main short-term risk, naturally, is causing too much vasodilation, leading to excessive hypertension or low blood pressure. This requires continuous, close monitoring, ideally in an ICU setting, using an infusion pump. However, with prolonged infusions, usually more than 24-48 hours, or very high doses, there's a significant risk of cyanide and thiocyanate toxicity. These toxic metabolites are byproducts of nitroprusside breakdown. Cyanide toxicity can lead to severe lactic acidosis and cellular hypoxia. Thiocyanate accumulation, especially if kidney function is poor, can cause symptoms ranging from fatigue and disorientation to toxic psychosis and hypothyroidism. Monitoring metabolite levels might be needed during prolonged use, and specific antidotes like sodium thiosulfate can be given concurrently to reduce cyanide risk.
Wow, that's an incredible level of detail on all the different drug classes. It's a complex landscape. How do clinicians navigate this vast array of options to choose the right medication or combination for the right patient?
Yeah, it definitely is complex. When we connect this all back to the bigger picture, the choice of an antihypertensive drug is, or at least should be, highly individualized. It's primarily driven by the likely benefit for that particular patient. You have to carefully consider any other medical conditions they have, concomitant diseases like diabetes or coronary artery disease. And you also have to anticipate potential problematic adverse effects of specific drugs for that specific individual. What might be fine for one person could be intolerable for another. Thankfully, as you mentioned, costs have become less of a deciding factor for many of the main classes, as ACE inhibitors, ARBs, most CCBs, diuretics, and beta blockers are now off patent and widely available as low-cost generics.
So, if a patient has hypertension and another significant condition, does that heavily influence the drug choice? You mentioned compelling indications.
Absolutely. These are called compelling indications, and they strongly guide therapy. While there's a general consensus now that blood pressure lowering itself is the most important goal for reducing overall risk, and large trials haven't shown major outcome differences based purely on drug class for general, uncomplicated hypertension. Current evidence does support a better overall benefit-risk ratio for certain classes in specific situations. ACE inhibitors, ORBs, calcium channel blockers, and thiazide-type diuretics are generally preferred as first-line agents in patients with essential hypertension without other specific compelling reasons to use something else.
But when those compelling indications are present,
Right, when they are present, the choice becomes much more specific, driven by the coexisting condition. For example, a hypertensive patient who also has heart failure with reduced ejection fraction should ideally be treated with a specific beta blocker proven effective in HF, like carvedilol, metoprolol succinate, or bisoprolol, an ACE inhibitor, or ARB, or an ARNI, a diuretic for fluid management, and in selected patients, an MRA, like spironolactone or eplerenone. These drugs directly benefit heart failure, even independent of their blood pressure lowering.
makes sense. What about diabetes?
For diabetics with hypertension, particularly if they have protein in their urine indicating kidney involvement, ACE inhibitors or ARBs are strongly recommended as first-line therapy due to their established benefits in slowing the progression of diabetic nephropathy. For patients with known coronary artery disease or post-MI, beta blockers and ACE inhibitors IRBs are often key components. For stroke prevention, diuretics and ACE inhibitors RRBs have strong evidence. The choice is tailored.
Beyond just those major cardiovascular conditions, do other, maybe less severe comorbidities or individual patient factors influence the drug choice?
They definitely can and should. Other coexisting conditions can tilt the balance towards certain drugs. For instance, as we mentioned, a hypertensive man with symptomatic benign prostatic hyperplasia, BPH, might particularly benefit from an alpha-1 blocker, as these drugs effectively treat both conditions. Kill two birds with one stone, so to speak. Similarly, a patient who suffers from frequent migraine attacks might get extra benefit from certain beta blockers or calcium channel blockers that also have migraine-preventing properties. A woman at high risk for osteoporosis might benefit from the calcium-retaining effect of thiazide diuretics.
And pregnancy.
Pregnancy is a huge consideration. As we discussed, for pregnant hypertensive patients, certain drugs that are otherwise rarely used now, like labetalol and methyldopa, become preferred agents due to their established safety profiles for both mother and fetus. Conversely, very popular and effective drugs like ACE inhibitors, ARBs, and direct renin inhibitors must be absolutely avoided throughout pregnancy due to the significant risk of fetal harm.
Okay. Beyond tailoring to specific conditions, what are the general pharmacological principles that guide clinicians in building optimal drug regimens? What are the key rules of thumb?
There are several crucial principles, yes. First, thinking about pharmacokinetics and patient compliance. Hypertension is a chronic, often lifelong, asymptomatic disease. This makes patient adherence to medication absolutely paramount for long-term success. So antihypertensives should ideally be chosen that provide consistent blood pressure control over 24 hours with convenient once-daily dosing whenever possible. Longer half-life drugs generally provide smoother control. Drugs with stable pharmacokinetics, meaning low potential for drug interactions and minimal influence from common genetic variations, are generally preferred.
What's next?
Second, rational drug combinations. As we've seen, a large majority, probably 2/3 or more of patients with hypertension will require 2 or more different antihypertensive medications to achieve adequate blood pressure control. Therefore, it's generally recommended to start combining drugs from different classes at low to medium doses rather than continually pushing the dose of a single drug higher and higher, which often just leads to more side effects without much added benefit. Using fixed-dose combination pills where 2 complementary drugs are in a single tablet can significantly improve compliance by simplifying the regimen for the patient.
Makes sense. What else?
Third, strength of scientific evidence. Whenever possible, treatment choices should be guided by data from large, well-designed, prospective clinical trials. These provide the highest level of confidence for a beneficial risk-benefit ratio and are a strong reason to choose one drug or strategy over another. Fourth, pharmacodynamic synergy. While not always formally tested head-to-head in trials, certain drug combinations make more physiological sense than others based on how they interact with the body's systems. For instance, thiazide diuretics enhance the actions of pretty much all other classes. But combining them with RAS inhibitors, ACEs or ARBs, is particularly sensible as the RAS inhibitors help counteract the thiazide's main risk, potassium wasting. And fifth, careful consideration of adverse drug effects and contraindications. While the major classes are generally well tolerated, clinicians must be acutely aware of the notable exceptions, specific contraindications, and potential side effects for each drug when choosing for a specific patient. Starting antihypertensives at low doses and employing a slow dose escalation strategy can significantly reduce the risk of side effects like hypotension or excessive bradycardia.
You mentioned hypertensive emergencies earlier. Just to clarify, is that treated entirely differently from this chronic management we've been discussing?
Yes, very much so. The principles we've just discussed apply to patients needing long-term risk reduction for chronic hypertension. Hypertensive emergencies are an entirely different beast. These are immediately life-threatening situations where dangerously high blood pressure is causing acute, ongoing damage to vital organs. The brain, encephalopathy, stroke, the heart, acute heart failure, myocardial infarction, aortic dissection, the kidneys, acute failure.
So speed is critical.
Yes, in these acute settings, clinical judgment strongly dictates rapidly lowering blood pressure to prevent further organ damage. Intravenous medications are typically required for prompt and controllable reduction. However, and this is crucial, rapid blood pressure reduction carries its own considerable risks. If blood pressure is decreased too quickly or too extensively, blood flow to vital organs, especially the brain, can diminish significantly, potentially causing ischemic injury. This happens because, over time, the brain's circulation adapts to protect itself from the consequences of very high pressures, a process called autoregulation. Disrupting this adaptation too abruptly can be harmful.
So it's a delicate balance.
Exactly. Clinicians must resist the temptation to treat patients solely based on an extremely high blood pressure number in isolation. Appropriate therapeutic decisions must encompass a careful assessment of how well that patient's major organs are actually reacting to or being damaged by the very high pressures. The treatment goal and rate of reduction depend heavily on the specific clinical scenario. Many different IV drugs can be used, but the choice depends on the situation.
Okay, that clarifies the emergency setting. So what about those challenging patients whose blood pressure just won't come down adequately, even when they seem to be on multiple medications? This resistant hypertension sounds incredibly difficult to manage.
It is indeed challenging and unfortunately not uncommon. Some patients with hypertension do fail to respond adequately to recommended antihypertensive treatments, even with 3 or more drugs, including a diuretic. This is defined as resistant hypertension. There are many potential explanations that need to be investigated.
What are some of the most common reasons?
One common cause is simply inadequate therapy. Either the doses are too low, the combination isn't optimal, or perhaps not enough drugs are being used. To achieve stringent blood pressure goals, especially the lower targets we aim for now, many patients genuinely require optimal doses of 2, 3, or even 4 appropriately selected drugs. Sometimes clinicians might be hesitant to push doses or add agents. Another very frequent, though sometimes difficult to ascertain, cause is patient non-adherence to their prescribed pharmacological regimen. Are they actually taking the pills as prescribed? Sometimes it's about irrational drug combinations. For example, combining 2 drugs from the exact same class that work by the same mechanism is generally not rational or additive.
What about lifestyle factors?
Absolutely. Excess dietary salt intake is a huge factor. And the tendency of some antihypertensive drugs themselves, especially direct vasodilators like hydralazine or minoxidil, to promote salt and water retention, can counteract the effects of other drugs. Consequently, inadequate diuretic treatment is a very commonly found cause of resistant hypertension. Ensuring the patient is on an adequate dose of the right type of diuretic is often the first step.
Are there underlying medical conditions?
Yes. A relevant fraction of patients with resistant hypertension actually have undiagnosed primary hyperaldosteronism producing too much aldosterone. These patients often show a significant, sometimes dramatic benefit from the addition of a low dose of an MRA like spironolactone, typically 25 to 50 milligrams daily. This was clearly shown in the Pathway 2 trial. And finally, we have to consider interfering medications or substances. Patients may be taking prescription drugs, over-the-counter drugs, or even herbal preparations that actively oppose the actions of their antihypertensive drugs.
Like,
Common culprits include NSAIDs, like ibuprofen or naproxen, sympathomimetic decongestants found in cold remedies, certain immunosuppressants like cyclosporin, erythropoietin used for anemia, herbal supplements like ephedra, ma huang, or even large amounts of licorice. And of course, illicit drugs like cocaine and amphetamines can raise blood pressure significantly.
so it requires a thorough investigation.
Absolutely. It is imperative that the physician thoroughly inquires about a patient's entire medication list, including OTCs and supplements, reviews lifestyle factors like salt intake, assesses adherence, optimizes the diuretic regimen, considers secondary causes like hyperaldosteronism, and then individualizes the antihypertensive regimen accordingly. Managing resistant hypertension really requires detailed detective work and a truly holistic view of the patient's health and habits. Hashtag tag outro.
What an absolutely incredible deep dive into hypertension. We've really covered a vast amount of ground, from its global impact and those evolving definitions, through the intricate mechanisms of all those different drug classes, and finally, how personalized medicine and tackling resistant hypertension are shaping treatment today. Yeah, it's clear the journey to effective blood pressure management is definitely not a one-size-fits-all approach, is it? It demands a really sophisticated understanding of pharmacology, careful attention to individual patient needs, comorbidities, potential side effects, and a persistent commitment to ongoing monitoring and adjustment. It's not a set it and forget its condition.
Indeed. And you've heard about the profound impact of even seemingly small blood pressure reductions on long-term health. We've touched on the sometimes surprising differences between drugs that seem similar on the surface, like hydrochlorothiazide and chlorthalidone, and the critical importance of avoiding common pitfalls, like suddenly stopping certain medications or underutilizing diuretics when they're really needed. And remember, the ultimate goal through all of this complexity is not just to lower a number on a machine, but to fundamentally decrease that person's cardiovascular risk and genuinely improve their quality and length of life.
So, reflecting on all this detailed knowledge we've unpacked about blood pressure, its relentless incremental risk, and this vast, sophisticated array of precise pharmacological interventions we have, here's a thought for you to mull over. If we can so precisely measure and manage arterial pressure, which at its core is merely a physical force exerted by fluid in a tube, what other seemingly simple biological parameters in our body might be secretly harboring complex, profound risks that we are only just beginning to truly understand and master? Thank you for joining us on this deep dive. Until next time, stay curious and keep learning.